Good morning, everybody. Welcome to Pediatric Grand Rounds. Thanks to all of you being here. Most of you are online today, so for those of you online, please remember to stay muted during the presentation. But if you have questions or comments at any time, you can enter them into the chat box, and I will ask your questions at the end of the hour. You'll be getting an evaluation by email, and there's also a QR code, so please make sure to fill that out. It really helps our planning committee. And speaking of our planning committee, we have no relevant financial relationships to disclose from the planning committee. So now I get to introduce our two fabulous speakers for today. First, Dr. Suzanne Steinman, who is a pediatric orthopedic surgeon at the Orthopedics and Sports Medicine Department here at Seattle Children's, and an associate professor at the Department of Orthopedics and Sports Medicine at the University of Washington School of Medicine. She did a residency in orthopedic surgery at University of California in San Diego, and also completed 2 fellowships, one in pediatric orthopedic surgery and another one in pediatric hand and upper extremity surgery. She joined our faculty in 2011. Is that right? Great. Her special interests include pediatric upper extremity, encompassing congenital differences, neuromuscular disorders, and trauma. Also, Dr. Raymond Say, who is an associate professor at the University of Washington and director of the brachial plexus program at Seattle Children's Hospital. His clinical focus is in pediatric plastic surgery with special expertise in cleft lip and palate, ear reconstruction, brachial plexus palsy, and hand surgery. Welcome to you both. We're so excited for this topic today. Thanks.
Hello there. All right, I'm going to try to remember to look up at the...
Got you. You can look at me.
Okay, I can look. There we go. Okay. Hi. Thank you, everybody, for coming this morning. So we're going to be giving an update on congenital hand anomalies. I first just wanted to kind of give a little... You'll see our little focus group here of our PD hand team. I'll get to that a little bit later, but I also just wanted to let everybody know this is our team that really sees congenital hand, but all of our APPs and a lot of other providers in the orthopedic clinic all see hand trauma. So I just wanted to, we have a huge team that's seen PD hand here at Children's. We have no disclosures. So objectives for today, we're going to go over the embryology of hand development. We're going to identify some of those more common congenital hand differences, as well as delve into the little more crazy, and then differentiate which conditions can be followed and managed initially by a primary care doctor, what should be referred to a pediatric hand specialist, and what requires immediate attention. So again, here's our hand team. So for our providers, we have Jeff Friedrich, myself, Raymond Say, Doug Dito, Cheryl Parker, and Alfonso Flying Cloud. So these are some of the names you may see on referral notes. But we also have a wealth of occupational therapists, which is something very unique that we're able to provide for our patients who come that day in clinic. We have Heidi Allen, Pam Horn, Debbie Howard, and Peggy Smith. So we're able to give one-stop shopping to our families that come. So etiology of congenital hand issues, 60% is sporadic. We do not figure out why this happens. Something important that I always let my families know is there's nothing that you did that caused this. There's nothing you could have done to prevent this, because there's a ton of guilt that happens in families when their baby is born not how they expected. 30% are genetic and 10% are environmental. So the embryology, this is all that stuff that you never thought you'd have to think about after your first year of med school. But this is super important to a congenital hand. So important to remember that upper limb development is happening at about 4 to 8 weeks of development. I always like to say that the legs are dumb and they lag behind us by 48 hours, so hands are the important ones. So again, limbs form early, 4 to 8 weeks of pregnancy. So this is happening usually before a woman even knows she's pregnant. And the things that are so great to think about and remembering your embryology, remembering all those little construction materials, all those transcription factors and all that stuff are made right on site. You have little internal GPSs that are directing where they go. You have these gradients that help to tell what develops where. But the really important thing to remember is what other systems are developing at the same time. Because if you identify one of these hand issues, that leads you to then think about what other organ systems could potentially have been affected. And it's frozen. No. All right. There we go. Okay. So again, back to our little developmental plate. Second week, we have our, our neural groove, our notochord plate. Things are starting to develop. We're getting our mesoderm, which is super important, and the neuroectoderm. And then by third week, you have the mesoderm coming out, your neural outgrowth coming in behind it. And that gets us then to the fourth week. And this is where the limb bud starts developing. So again, roughly the fourth week, we get limb bud initiation, and that's by the Hox genes. And this stimulates mesoderm proliferation. And it's maintained by the FGFs primarily, and some other of the transcription factors. But that proximal to distal limb bud development, again, FGFs, Hox genes, and mesoderm proliferation. And the reason why I talk about proximal to distal is there are actually three patterns or axis of formation during limb development. You have proximal to distal, you have anterior to posterior, or your cranial caudal, or your radial ulnar. So you actually have something telling you where to put a thumb, where to put a pinky. And then dorsal ventral. You also have something telling you where to put the thumbnail, where to put the pad. So again, if there's a problem with that proximal to distal development, that's where you get those transverse loss of development. So for that proximal to distal development, you have your AER, your apical ectodermal ridge. These are some of the things you might have remembered from some of your exams. This is a little advancing like mobile DNA command center where you have all those transcription factors and you're getting your gradients. The FGFs, again, are involved in maintaining this outward growth. And you have your AER here. It's supported by the progress zone and this little vessel that's here. And the reason why that little vessel, and I'm just going to go back, is important is because if you have failure of the development of that little vessel, that again is where we see a lot of our congenital loss distally, and we'll get back to that in a minute. But these are the chick studies where if you move your AER, the wing fails to develop. So you fail to get that distal development. So proximal to distal, AER, progress zone, FGFs. So next, we have our cranial caudal or radial ulnar or tib-fib development, and that is supported by the ZPA or the zone of polarizing activity. It's at the caudal edge of the limb bud, and this is, again, Hox genes, but sonic hedgehog in particular. And yes, it was named for that fantastic little game in the 90s initially. And so again, this is that interplay of concentration gradients where you get if you get more of one of the transcription factors at one end, you get the ulna, and the other, you get the radius. And if there is a problem, that's when you get failure of developments or a mirror wing. So these are those studies where in the chick transplant, where if they move this, you get a mirror wing. So again, there they are in that caudal edge. So cranial caudal or radial ulnar tib-fib, that's the ZPA, Hox, and sonic hedgehog. And then lastly, for that dorsal ventral development, this is regulated by the Wnt genes, and it's a dorsalizing signal as well as the LMXB1 genes. And again, it's that gradient that tells you to put a fingernail on top or a pad on the bottom. And in these studies, you sometimes would get the little flies with like wings on both sides of them. But a problem with this is when you might see nail patella syndrome, different things like that. So again, dorsal ventral, Wnt dorsalizing. So that gets us to like week 6, where we're getting the mesenchymal condensations. We're starting to get some little separate finger grooves, and then the limb buds start to rotate, and you start to get separation of fingers. And that is the final act of the AER, apoptosis, where you start to get the interdigitating of the fingers. So everything starts as a paddle, and then they start to separate. And if there's a problem with this, that's when you start seeing syndactylies and things like that. So we have this, I call this the oh my God classification. It's the OMT classification. It's the new way we are now classifying congenital hand differences. And this is actually a way for PD hand surgeons, developmental pediatricians, geneticists, everybody to be able to talk on the same level. And the reason why I went over all the patterning is because this is based on the patterning. Either whole limb involvement, so you can see we have entire limb, proximal to distal, radial ulnar, dorsal ventral, or unspecified, and then hand plate. Oberg, Mansky, and Tonkin were a group of developmental pediatricians and surgeons, and this is how we are now classifying things. And then we also just then have our deformations and dysplasias. So kind of going over, I'm just going to do a brief little overtalk here of some of the more common things that you might see coming in, and you get the first exposure to it. For polydactyly, most common congenital hand difference we see, it is more common in the Black population. This is a problem of that segmentation. It gets just one extra little signal for segmentation. And you can have it ulnar, radial, central. It is associated with lots of hereditary conditions. So I do a full naked baby check in my clinic. A baby comes in with a little dangly polydactyly, that baby gets naked in my clinic and I check everything. So making sure that you check for any other issues, and it can be associated with other anomalies, especially the big bony ones on the pinkies can be associated with things on the feet, so checking the feet out. For thumb involvement, this is non-urgent. We usually do not do the surgery for this until they are at least a year of age. Because anatomy is bigger, it's safer for anesthesia. If we can wait till 2 for any of these surgeries, we wait until 2 so that it's safer for anesthesia. But again, this is not urgent, but a lot of the times families have tons of questions. So I am always, the whole team, always happy to see families in earlier, because that initial visit, we're usually never doing anything for the baby at that visit. It's more talking to the family, giving them information and reassurance. But again, this is non-urgent and can be followed, just making sure you do that full naked baby check. When it's the pinky, this is called postaxial. A type A has that bone component, so it's like a real well fully developed finger. And those, again, non-urgent, we usually don't do the surgery on those until they're at least a year of age. But again, making sure to check the legs and the feet. For the type Bs, these are those little soft tissue, little dangler guys. And it's very tempting to want to tie some of these off. If you are going to tie one of these off, make sure it is the ones that are like the dental floss width. If you try to tie something off that's bigger than that, what happens is it'll fall off eventually, but you will get a sensitive neuroma on it, and then they wind up needing to have a revision surgery to remove that neuroma when they get a little bigger, usually 2, and they hurt when they color because it rubs on the ground. But if, not the ground, the table. But what we will do, again, if they're small enough, is some of us will, if it's small enough and they're young enough, clip it in clinic. What I like to do is I clip these. So you have this itty bitty little dangly guy that's tiny. I don't like to use a suture because, again, I worry about the development of that neuroma. I use a little vascular clip. I numb it up and tell the family this is just like one of your shots. So they get a little lidocaine. You get these itty bitty microvascular clips. I put 2 of them at the base of it, and I run my finger over the base of it. You can oftentimes feel the neurovascular bundle snap, and that tells you that that little nerve's going to migrate a little proximally. So it's out of the way and away from where it's healing to help diminish that chance of developing a neuroma. And then you wrap it up and hide it for 2 weeks, and when they come back, it's shriveled up and fallen off like the belly button, and family totally understands that. Again, if you tie one of these off in your clinic, make sure you wrap the hand, because what happens is if they're just kind of left there dangling, they get really irritated. They blow up to like the size of a grape. So if you do this, wrap it up and hide it for 2 weeks. All right, so absence of parts. This is that failure of axis development. Many diagnoses with fewer than 10 digits present. Again, families oftentimes come to see us, for that early information and counseling. We're rarely doing anything in a first visit for treatment, but our goal for these kids is functional independence. My line I like to give families is the 2-4 rule. It's not what I can do to your child, but what I can do for your child. So just because there's a surgery that they might read about on the internet doesn't mean that that's the right thing for their child, that it will help them. So it's really about their function and what's going to help them the best. So 2 things that you often will see in clinic before us and refer to us that can sometimes get confused, but it's really easy to determine the difference, and you can give families a lot of reassurance between these. Amniotic band and syndactyly, and they look very similar because oftentimes you're missing bits. Amniotic band, that is like ensnared parts. These are a true amputation or injury that happens in utero after the hands have developed. So they went through the full 8 weeks, things developed, and then something happened afterwards, whether they got ensnared in amniotic band or something. Syndactyly, this is that problem of the proximal to distal development. It's a mesoderm minus hand. You can think of it that way. It has all the ectoderm, so it has little nubbins often and little fingernails, but it's missing the mesoderm, so it's like didn't have enough filling in the toothpaste tube. So amniotic band, this is again ensnaring or constriction. It has a lot of varied presentation. This is rare, very rare, where we get the band so badly that there's an imminent amputation. I've had maybe 2 of these in in all the years that I've been, even in my fellowships, I've seen maybe 2 where it was an imminent amputation. More commonly, we see these fenestrated syndactyles where you can see the finger formed and then something just banded it or scarred it. You see these bands, edema. You will see it in multiple locations, and it will usually involve more than one limb. It can also be associated with club foot and cleft palate. So if you see it on more than one extremity, you see banding in other locations, loss of fingernails, you don't have that ectoderm, that is amniotic band, and that is an amputation. Versus syndactyly, this is a problem of that little vessel that is supporting the progress zone in the AER. So something happened, it's the subclavian artery disruption sequence. And so that little vessel is actually the subclavian artery that's coming down. And at some point it had some kind of problem in development, and development stopped there. You still have the ectoderm at the end of the AER, so you still have the ectodermal elements, so you get these little nubbins, you still have fingernails, but things are short. They might be syndactylized. You can get Poland anomaly where if a problem happened even higher up, they can have problems with development of the pect. If it's even higher, this can rarely be associated with Mobius syndrome, but that's not as common, but it can be associated. This is always single arm involvement. You do not see banding or involvement of other extremities, and you have nubbins with nails. And one of the reasons why this is important is to kind of be able to distinguish the two. And so neither of these are genetic, and they're isolated. Again, usually they're not associated with other issues except for what I just talked about. So you don't have to do any additional studies for these. For amniotic disruption sequence, urgent referral if you have that impending tissue loss, but usually it's not there. So it's usually non-urgent, but early referral if family needs instructions. Sometimes we do splinting. We do the surgeries again, usually once they're 2 years of age, if we can wait that long. And the reason why it's important to distinguish these is since this is an amputation, they can get appositional overgrowth. So in kids who have a long bone amputation, because that bone is still growing, you get growth at the end of the stump. And so they can get those painful stumps, painful nubbins that might need a revision. So we actually have to follow amniotic band kids more closely than syndactyly kids. So if you remember Shaquem Griffin, who was our Seahawk, who had one hand, he had amniotic band. And if you remember hearing the stories where he had a revision amputation because his hand hurt so badly, that's essentially kind of what happened. Versus syndactyly, again, this is not, again, genetic. They have nice ectoderm at the end of it, so they do not get appositional overgrowth. We will refer them oftentimes to rehab a little earlier if family really wants to talk about prosthetics. Kids hate prosthetics. They don't use them. They cover up their sensation. They're heavy. They outgrow them quickly. Usually around maybe the age of 7 and older, there's a specific activity they might want to do, so they'll start asking for the use of one. And so we'll give them information. A really great site is eNable, E-Nable, and they do online 3D printed prosthetics, like the Iron Man hand. So if a kid is really excited about that, they get to pick their color. They match up with a person who will 3D print it and send it to you. So that's a fun thing for kids to try out if they're interested. Or we also have a fantastic prosthetics department where we can make special adaptations for musical instruments, specific activities, sporting equipment. All right, radial dysplasia. So lots of names, club hand, all that. It's a huge broad spectrum. It can be small thumb, absent thumb, triphalangeal thumbs, short absent radius. 1 in 30,000 live births, so not that common, but super important to identify because this is one where at the same time that the radius is developing, several other organ systems are. So knowing what those associated conditions are. So this is like if you see a small thumb or a missing radius, that's just the tip of the iceberg. You have to think about all the other organ systems that we're developing. So cardiac system, renal GU, vertebral, and hematopoietic. So when one of these babies come into my clinic, even if they have a slightly short thumb, I get a CBC with diff, cardiac echo, EKG, renal ultrasound, spine ultrasound, x-rays. And so if you guys identify this in your clinic, you can get that workup going. Now, if it's VOC-Durrell, they've already had this done because that's been identified. But some of these kids, it's really subtle. Or sometimes we've gotten them where it's a dangly thumb because it's so hypoplastic and it'll have been mistaken for an amniotic band. So if you see something abnormal on the radial side of the hand, not the polydactylies, but hypoplastic or missing, they need to have the workup for radial dysplasia. And we're happy to do that also. Just identify it, send it to us, and we're happy to do that workup as well. So early referral for stretching, lots of OT. Usually we don't do surgery until, if we can wait till 2 years of age, but lots of different things you can do for this, and families will look this up online. But again, it's individual treatment. Syndactyles, this is that problem of apoptosis. It can be, again, familial or with syndrome, so they get the full naked baby check. Many presentations. Again, we try to wait till they're at least 2 years of age unless it's tethering. So like if the thumb and the index finger are together, it'll cause more and more deformity as they grow, so we'll release those a little bit earlier. Things we separate, so fingers, toes get a lot of referrals to us. We only separate toes if it's the big and the second toe and it's tethering. And so if you have a family in who wants that referral for toe separation, just tell them, nah, you're going to be great. The toe separation causes a lot of scarring. So you can give them some reassurance and try to save them that visit. But yeah, we only do the toes if they're tethered. So early referral, especially if it's a border digit, but otherwise you can, reassure them if they want to come talk to us though. Again, always happy to chat and give reassurance, but usually we don't do these until they're at least a year of age. So urgent referrals, that would be that amniotic band with impending tissue loss. And that is essentially the only thing in congenital hand that needs an urgent referral. Non-urgent referrals would be the polydactyly, syndactyles, radial dysplasia, absent parts, amniotic band syndrome that doesn't have an impending skin issue. Again, always happy to talk to families early because they have tons of questions, but you don't have to make mom get out of bed, on post-birth day 3 to come see us. And that will lead us to Ray.
Okay, so I'm going to go through a few other presentations and give some clinical examples. And this saying that I'm all thumbs is a bit of an ironic one because the thumb is actually the most important digit in the hand. It's responsible for prehension, the ability to get your thumb wrapped around so that it can interact with the fingers. And that's what sets us apart from a lot of the rest of the animal kingdom and provides us with abilities to achieve all sorts of tasks using our hands. Prehension occurs according to a well-defined set of developmental milestones. At 6 months, there's a raking grasp. At 9 months, there's a pincer grasp. And that development continues over the next few years. And so one of our goals of treatment is to try to optimize anatomy by 1 or 2 years of age to hopefully facilitate and optimize functional outcomes in the long run. So I'm going to take a little step back and talk about syndactyles. They can be simple and they can be incomplete. And with simple releases, little extra skin, the appearance can end up being quite natural. When it comes to a complete syndactyly, there are gains from releasing the fingers so that the fingers can move independently. The release is much more extensive, but at the end, we can still produce an appearance that is fairly natural. Things get a little bit more complex when there's bony involvement, and if you look at the image on the right, you can see that the nail plates are fused together, and that indicates that the bone underneath is also fused together. Things get even more complicated when you have not only side-to-side fusion of fingers and bones, but longitudinal fusion of bones, or when the little finger's also involved with it, and there's this rotational fusion or deformity of the digits. And even more complex when the entire hand is involved and the thumb is stuck in that big mass of fusion. These are examples of kids with Apert syndrome. Acrocephalosyndactyly is oftentimes related to an FGFR2 mutation. It presents in an autosomal dominant manner and can involve, or not can, and in terms of the presentation, it does involve multiple suture craniosynostosis, mid-face hypoplasia with or without cleft palate, the hands obviously with multiple complex fusions in the transverse and longitudinal orientations, as well as syndactyles of the toes in the feet. We do go ahead with early surgery for these kids for a few reasons. The first is that the fusion is progressive and gets to be more extensive over time. Because these kids are moving their hands and fingers, what happens is the joints will start to accommodate to that, and so the deformity worsens with growth and it becomes more apparent after release. Last, there's many stages to reconstruction, and so if we can coordinate carefully these stages of hand surgery with the posterior cranial vault distraction, the frontal orbital advancement, hopefully by 2 or so years of age, we can have all the fingers free, moving independently so that a kid can go on to continue to develop their motor skills and figure out how to use those hands. What is probably most important that we do for these kids is to release their thumbs from the big mass. And you can see how tightly that thumb is stuck with a mass of coalition of digits. On the images on the right, you can see how tight things are on the volar surface of the hand. You really have to pull things and pry things apart to actually see that there's a deep kind of crevasse or pit in there. With early release, there's a large area that needs to be resurfaced. And with that release, you can see that now the thumb is able to move away from the fingers and now is able to interact potentially with the fingers down the road. What you'll also notice with the thumb, though, is that even though we've released the thumb, it's still deviating away from the digits. The bottom right image shows it nicely, and that's because in addition to all these fusions with Apert's syndrome, there is a clinodactyly of the thumb. Clinodactyly is Latin for bent thumb, or bent digit. And I'm going to back away from the complicated situation of Apert syndrome and just go into simple clinodactylies. When we see kids with clinodactylies, deviated digits, if they involve the fingers, we generally don't do a lot for them because it's of relatively little functional consequence. When it involves the thumb, though, the deviation of the thumb makes the thumb effectively a bit shorter, and so we will treat these kids with thumb clinodactylies. When the thumbs are involved on both sides, it's generally a presentation of Rubinstein-Taybi syndrome that can be related to mutations of Krebs binding protein, EP300, short arm chromosome 16, and some other potential mutations that are yet identified. It's inherited in an autosomal dominant manner and involves distinctive facial features, broad thumbs and first toes, and can have some cognitive implications. Here's an X-ray of a child with Rubinstein-Taybi, and to just review X-rays of hands, there are 3 phalanges, the distal, middle, and proximal. There's metacarpals in the hand, and then there's the carpal bones, the bag of bones in the wrist. For each of the long bones, there's a physis, a growth plate, that isn't visible on X-ray because it's mostly cartilage, until you get a little bit of ossification of the epiphysis, which you can see in the proximal phalanx. On the other side, the metacarpals, the growth plate is on the other side of the long bone. And so when you're looking at these X-rays and trying to sort out what you're seeing here, it's helpful to have that orientation. If you look at the thumb, there are 2 phalanges, and if you look at the proximal phalanx of this thumb, it's got a bit of a trapezoid shape. We call this a delta phalanx, and it's that shape because the physis is longitudinally bracketing that bone. And so for what we'll do for these kids is we will make an incision as a Z-plasty, and it's a little plastic surgery trick where if you incise a Z, you raise the flaps, you transpose the flaps, you can add length to that side. And as we straighten this thumb out, it's going to get tight on this side, so we want some extra looseness. Under the surface is the abductor pollicis brevis muscle. It's the tendon insertion of the thenar muscles that's important for abduction of the thumb. This tendon is not normal in its insertion, though, because it's inserting onto the base of the distal phalanx rather than on the proximal phalanx. So we'll elevate that tendon. We'll then make our cut in the bone. We'll straighten the thumb. And then we'll put a little piece of bone graft in there to wedge it open. We'll then take the abductor pollicis brevis tendon and place it into the base of the proximal phalanx where it normally would belong so that it's no longer a deforming force as this child grows and so that that thumb can remain straight over time. This is right after we're finished straightening the thumb and then a few years later. And what's interesting, or I find fascinating with these situations, is that we can leverage growth to normalize things. If you look at this phalanx, it now looks like a normal phalanx with a proximal growth plate, as compared to the delta phalanx from before. And so if we're careful about what we do, we can leverage growth to our advantage. What about the Apert clinodactyly? Back to that very complicated situation. We generally use the same approach for these kids, but if you look at the proximal phalanx in these hands, they're very hypoplastic, very, very small, and they've got this triangular shape. But if we're careful about what we do and make the cuts nicely, we can straighten the thumbs out and we can produce a phalanx that's more normal in its configuration and that potentially becomes a candidate for distraction and lengthening to get a better effective prehension sometime down the road. And so thumbs are important. When examining a newborn baby, I think it's important to carefully examine the thumb because there can be some subtleties that aren't that obvious. If you look on the left, the child has a hypoplastic thumb. There's a subtly tight first web space. You probably can see it better if you're actually manipulating the hand. But what's more remarkable here is the absence of the thenar eminence, the muscles in the radial side of the thumb, the meat of the base of the thumb, that allow the thumb to move in abduction and opposed to the other digits. If you look then at the images from left to right, you can see that as the thumb gets more and more hypoplastic, the wrist starts to deviate more, and clearly thumb hypoplasia is part of the spectrum of radial dysplasia that Suzanne talked about. If it's a mild thumb hypoplasia, the example is on the right side, these kids can probably still touch their thumb tips to their index finger tips, but their power and their strength of doing so may be limited, and it sometimes can be a little bit more difficult. If you look at the x-rays on the bottom, there's a well-formed thumb, but the bone is a little bit more hypoplastic, and you can see that tightness of the first web space. And so for this situation, we do a few things that are relatively simple. We can do a 4-flap Z-plasty in the first web space to broaden that and widen that. And then we go over to the ulnar side of the hand and borrow the abductor digiti minimi and transpose that into the base of the thumb so that it can replace the absent thenar muscles in bringing the thumb into abduction so that it can pose against the digits and provide a greater power in pinch and oppositional prehension activities. In a situation where the thumb hypoplasia is more severe, there's either an inadequate thumb or there is no thumb, it's pretty simple. We need to build a new one. Sometimes we get into these situations where there's a gray in between. There's a thumb, pretty well formed, but is it a functional one, and is it one that we want to augment, or are we better off building something de novo? And there are some criteria that we use to try to make that decision, but development also sometimes dictates what we ought to do to improve a kid's function. And so if you look at the image on the right, this kid has been using the index finger as their thumb. You can see the finger is the skin finger, the skin of the finger has been chewed on, it's been sucked on. This child has been using their index finger as their soothing thumb. You can see that the finger is out of phase compared to the other digits, and that's because that finger has been pronating in attempts to oppose to the long finger. If you look at the photos on the right, this is the child using his left hand to grasp these puffies, and strangely, the thumb isn't involved in grabbing these puffs. It's actually the side-to-side pincer between the index and the long finger. And so this kid developmentally has patterns such that their index finger is their thumb. And if you try to augment the thumb that's there, this child was never going to use that thumb, so it's not a useful thing to do. And so instead, it makes sense to make that index finger into the thumb. We do that through a procedure called index pollicization. Pollex is the Latin term for thumb, and we're making the index into a thumb using incisions that allow us to move the index finger into the place of a thumb while rotating it, shortening it because the thumb only has 2 phalanges, and then positioning it in a way that the thumb or the index finger can now act as a thumb, interacting with the fingers on the other side and opposing them. And so while doing so results in a 3-fingered hand, if the position of those digits is natural in position, the hand can have somewhat of a natural appearance. But the biggest thing here is, from a functional perspective, it's a massive win because you can get tip-to-tip prehension and grasp and a very significant improvement in overall hand use. It's a game changer. And so I'm going to just shift gears now and talk about cleft hands, which from a treatment perspective can be a little bit of the opposite scenario of hypoplastic thumbs. And that's because kids with cleft hands have excellent opposition. There's a cleft, they've got digits on a radial side, digits on an ulnar side, those can oppose against one another, and so their function is actually quite good. The problem comes in the abnormal appearance and the desire to normalize that appearance. Cleft hands present typically bilateral, involving hands and feet, with an autosomal dominant pattern of inheritance. It can be associated with syndromes. EEC is ectrodactyly, ectodermal dysplasia, and cleft lip and palate. And if we're going to close the cleft, we need to maintain opposition because we can't trade appearance at the expense of function. And so we need to maintain function if we're going to alter the appearance. And so in many ways, what we're doing here is we need to move the index from a thumb position to a finger position and put it in a position with the other digits. Here's an unusual example of a child with an isolated cleft hand. On one side, it's too wide along the cleft. On the other side, it's too narrow along the first web space. So in blue, if we take the tissue from the cleft and then transpose it into a release along the first web space in red, we can achieve our goals. You can construct an intermetacarpal ligament to stabilize the fingers side by side, and then with the transposition of that tissue, you can open up the first web space. That leads to a natural appearance and then maintenance of prehension and normal hand function. Cleft hands can present a little bit more complex. This is a child with EEC. And there's fusion of the ulnar digits as well as the radial digits. So the first stage here is to release those syndactylies, and then come back another day to do what may be termed as an index digitalization, where we move the index finger from the position of a thumb to the position of a finger so that it can appear and function more like a finger while maintaining that breadth of the first web space so that there can be that maintenance of prehensile function and opposition. So as Suzanne alluded to, the embryology of hand development is quite complex, and because of that complexity, there's a vast array of presentations that sometimes don't fit into the clear-cut categories that we sometimes want to put them in. And because of that, it can be a little bit difficult to classify, at least precisely. For these situations, we follow our principles. We think about how we're going to try to make form as natural as possible, meanwhile maintaining or optimizing function and prehension. In the meantime, or with all of that, we also need to respect the fourth dimension, growth and development. And so hopefully we've convinced you that congenital hand anomalies are not just little problems in little people, but rather they can be associated with anomalies and syndromes. We've gone over some of those. There are potential genetic implications. We do need to respect growth because growth can make the deformity worse, but growth can also be leveraged to normalize or optimize function. We also need to respect development because it sometimes dictates a little bit of when we should treat children and then what to do. And I gave you that example of the hypoplastic thumb where a kid tells us what we ought to do for them. We've talked about form and function and biology, but kids with congenital hand anomalies do have social needs, and they have psychosocial needs. And so there are resources available. On the left are some books intended for children as well as for parents. And on the right are some online resources. The Lucky Finn Project's a great one. It refers to Nemo's buddy, Lucky Finn, and sometimes Finn feels like he doesn't quite match everybody else, but at the end of the day, he can be a hero, and so can these kids be. In terms of research, there are lots of questions to answer, and Suzanne's worked very hard to include our institution in the COULD registry, which is a prospective registry and a collaborative, including Boston Children's and CHOP, amongst a number of other prominent centers. And so there are a lot of things that we should and hopefully can answer in the future. And so Suzanne, I think, has done some heavy lifting going over the embryology, the development of the hand. We've gone over associated conditions and things to look out for. And I've given you a little bit of a show and tell of what we do for kids with congenital hand anomalies. And hopefully together that can help you improve the care that you provide for kids with these presentations. Thank you.
Well, we do have some people in the room. Thanks for coming in person. If you guys have any questions, raise your hands.
Here is one of our fantastic OTs.
Hi, thanks. Our OTs are here for those of you online. And and for those of you online, if you have questions, feel free to enter them into the chat. No. Do you have one? Do you want to talk? Talk.
Suzanne, you should go.
Dr. Say, with the surgeries, do you prefer to do them bilaterally or one hand at a time?
It all depends. I think, yeah, it's a good question because kids need to be in a cast for a period of time, and having two arms removed from a kid's disposition can be difficult. At a younger age, it's a little bit easier. At an older age, it's more difficult. Ultimately, I'll oftentimes leave the decision to families because there's advantages and disadvantages to each approach. If you do one side at a time, it's more events under anesthetic and the side effects and risks associated with that. But if you do both sides at the same time, you've got two hands bound up at the same time. What's remarkable, I find, is that there are a lot of kids who come into clinic with two arms in casts above elbow, and they are just fine. They use their arms, they use the cast, they use the cast to manipulate things, and most kids, I think, just go with it.
Those are amazing. The art on the screen right now is amazing. So kudos to your cast makers. I have a logistical question just because I'm an ER person. If we're referring someone, how easy is it for them to get in with you? And is there a telemedicine option for those who maybe the family needs to talk to you, but you don't need to actually examine the kid in person?
So yeah, so what usually happens is if you are in the ED and you call for an ortho consult, it winds up, and the resident doesn't have to necessarily go see them, but it winds up on our consult list. And we get an email every morning. I was just going over it this morning prior to this conference, where we are able to see all the consults that came in that night. And so that's one way. And so for some of the providers out there, if you have a question about a congenital hand and you call the ortho line during the day, it will get discussed and it will get put on our consult list if it wasn't discussed right then. You can also still, for the non-urgent things, put the referral in. And we are able to get the kids, usually and pretty easily. Right now it's trauma season. So the finger fractures are taking a little more precedent over some of the more non-urgent issues. But if there's something that you feel you really need to get in, call the ortho consult line or our TAP line, and it will get put on our consult list, and I review it every morning.
Amazing. That's great to know. Thank you. Logistics are important too.
This is for either of you. How do you think the hand anomalies affect hand dominance?
I definitely, and talking to families, so we actually, at Children's also, we have a limb difference social group that gets together, and we were able to have our first social just a couple weeks ago for the first time since the pandemic. The kids went rock climbing with Outdoors for All at Vertical World. Shout out to both facilities and institutions. But I will have parents oftentimes tell me that they saw them go in to try to use that limb initially, and then they transfer over. So, I mean, I think that, there was something definitely wired for them to potentially use that hand that was different, and then they convert over. But I think some of the kids oftentimes are more ambidextrous because they do feel like they want to be leading with that hand that was involved, but they just have better strength or grip or something with the other hand. But you can definitely see it in some of the kids that, yeah, there was a preference and it affected the involved hand.
Yeah, and I agree. I mean, I guess I think of hand dominance as a brain-driven phenomenon, and if the anomaly is mild and something like a syndactyly, I think a kid with a syndactyly is going to continue with their hand dominance according to their brain. But when it's a more significant difference, and if there's greater impacts on function, there is this kind of threshold where at some point, if they're impaired enough, they're going to just convert to the other side and not use the brain-driven side. So interesting phenomenon, interesting question.
There's a question in the chat. Can you say a few words on how you arrived at this super cool career choice? This is from Dr. Gibbs. I want to know that too.
Yeah, I mean, it's a great question, and I love what we do. I think of the years of quality of life years that we can provide for kids is immense when we do this work, and I guess that in many ways is the beauty and the beast because you lay awake at night thinking, well, how do we do this as best as possible because this is going to be for the rest of their life. And that's the beast, and the beauty is that we can do things and can help kids for the long run.
Amazing.
Yeah, I can say I had a very Seattle Children's directed placement into this. So I was a med student here, and I wanted to be a developmental pediatrician, and that had been my plan. And my third year of med school, I got my elective rotation first, and all that was offered was bench genetics or peds ortho. And I went with peds ortho because I thought I'll see the CP kids and be with the rehab department. And I got there and I was like, oh my gosh, this is the most amazing thing. You can, quote, fix them. Now I realize that's not quite what happens, but so that kind of led me down that path. And then just during my residency, realizing the hand function that you can restore to people and make such a difference in their life when there's a hand issue. So I have to give a shout out to Vince Mosca, actually. He was my mentor when I did my peds rotation here as a third year med student.
That is a great answer. It seems like that question was a plant almost. It was. All right, amazing. Anybody else in the room? I think we'll end with that. That is super inspiring in all directions. So thanks so much for all the work that both of you do and your whole team. And thanks for being here today. And to our audience, both in person and online, thanks, and we'll see you all next week.